Professor. So good day, everyone, whoever joined right now. So it's my pleasure to introduce Dr. Hayder Hashim, an interventional cardiologist at MedStar Heart and Vascular Institute and an assistant professor of cardiology in Georgetown University. So we warmly welcome you, Dr. Hashim, to our DCB Academy scientific sessions. So today he's going to be speaking about how to approach patients with ischemia or myocardial infarction with non-obstructive coronary arteries, i.e. INOCA and MINOCA, an increasingly important challenge in the current practice. So Dr. Hashim, the floor is yours.
Perfect. Yeah. Thank you, everyone. I do appreciate the opportunity. I know it's night in your time or evening. It's early morning here. We're about to start cases. I made this presentation. It was part of grand rounds that we presented at Georgetown. If you feel it's too basics, if you feel it's too boring, I could change it. If you are into how to do the testing, understanding the technicality in interventional cardiology, I could show you anything else. So in the middle, stop me, ask any question, say, you know what, we know this, boring, do something else, I'll do something else. To me, I got into this field 4 or 5 years ago when it first came to the United States, brought in by Abbott Vascular after they combined their business decisions with Coroventis, and they named the whole system as CoreFlow. And it's an area of interest in my research when I was a fellow 15, 20 years ago, but there was never much about it. It was a diagnosis of exclusion, if you would say. So let's try to understand the microcirculation better today. And I'll take you first with a simple case that comes to any lab in the world. Someone who, a young woman, a young man, it doesn't matter. Predominantly, it's a woman disease, but someone comes with hypertension, hyperlipidemia, GERD, and I always laugh about the reflex joke because we all have reflex. I drink coffee, 3 coffees a day, I have reflex. But is it truly my chest pain is GERD, or is it just part of the workup for chest pain that was never explained, and then we will call it GERD? She's asymptomatic first, and then a couple of years ago, she had a calcium score of 0. She's asymptomatic, hyperlipidemic with family history, and her calcium score was 0, and they put her on statins. But over the course of a year or so after, she started having episodes of substernal chest pain, mostly exertional, and gradually resolved with rest. So she does have typical angina. She was prescribed nitro to kind of abort these episodes, but she hated nitro because it gave her really bad headaches for about an hour after each time she takes it. She's on amlodipine, lisinopril, and atorvastatin for her risk factor modifications. Because she's having chest pain, exertional, they put her on a treadmill, and then they did a nucleus, they suspect, and then she has a upsloping ST depression, but she has a normal perfusion imaging. She has a normal LV systolic function, and there were no wall motion abnormalities on her echocardiography. So continue to have chest pain. EKGs are bad. We know EKG has different sensitivity or specificity, especially in the woman population. The cardiologist said, you know what, Hashim, can you take a picture? So we went in, we took these pictures. We probably all agree that there is mild to moderate disease in the LAD, kind of diffuse in the proximid. RCA looks angiographically near normal. And because she's in my lab, I said, you know what, let me see if the LAD is part of the problem. Sometimes angiography does not tell you the full story. So I put pressure wire X, I put a physiology wire down. I was able to get an RFR down that LAD of 0.96. To remind everyone, the cutoff is 0.89. This is a resting non-hyperemic index. It's measuring a full cycle, the most significant PD-PA ratio. It's different than IFR, it's different than DFR. I don't want to go into the physiology of things. But RFR is a resting full cycle ratio. It measures the highest separation between pressure distally and pressure proximally, wherever that lands. It could land in early diastole, in late systole, in late diastole, like this case, it doesn't matter. It will give you the highest gradient as a representation of epicardial compromisation of flow. We know the gold standard to understand physiology based on our clinical trials is FFR. So I went ahead and I induced her with adenosine, IV adenosine, to mimic as much as we can the physiology of exercise, and we were able to get an FFR of 0.94. So in the literature, this procedure is done. The case is over. She has chest discomfort, exertional. She had an abnormal EKG portion of the stress test. And then I did epicardial testing of the LAD, which had the most significant epicardial plaque burden, which still was mild to moderate at most. And then she has negative physiology. So the question now becomes, now what? Is this really GERD induced by exercise? Is it asthma induced by exercise? Is it really something else that we need to understand? This is the problem with angiography. Angiography sees the pictures on the left, does not see the picture on the right. And I always explain to my patients that the epicardial coronary arteries are actually the blue collars. It's the wealth, the money that controls the market. But without the blue collars, the capillaries, the arterioles, and the prearterioles, the working force, the wealth doesn't mean anything. The wealth brings the money into the business, and the business, the capillaries, will take over that money and start producing. For that reason, if we go back to basic science, we understand the conduit vessel, the LAD, the circ, the RCA, the major branches, they are contributing to 5% to maybe 10% in some literature of the resistance or functionality of the coronary circulation. So they truly, they do not participate in gas exchange, nutrient exchange, metabolic needs of the myocardium. They're just there to bring the blood from the aorta, fully oxygenated, dump it in the myocardium. Most of the work happens in areas that we don't even see on an angiogram, and that's the prearteriole, the arteriole, and the capillaries. They are responsible for most of the resistance and regulation of the coronary flow. We also have to understand that the structural changes that happens to an epicardial artery had already happened in the prearterioles and arterioles, because if I take you back here, you see that the layers of the prearterioles and arterioles mimic exactly what the epicardial layers are. They are endothelium, they have smooth muscle cell, and they have adventitia. So if you imagine that you have structural changes or plaque building up in an LAD, what had happened already in the arterioles and prearterioles. Same thing if you have a vasospastic functionality, vasomotor damage to the epicardial arteries, which means if you engage the right coronary artery and the right coronary artery collapses and you give nitro and that artery gets bigger, whatever reactivity malfunctioning you have in the epicardial arteries, that already translates into the microcirculation. So now you could have structural changes in the microcirculation, and you could also have vasospastic changes in the microcirculation. Therefore, there will be, in the next few slides, we will talk about epicardial vasospasm, and we will talk about microvascular vasospasm, because they both could coexist or exist separately. To drive you into the research mentality of how microcirculation is important, and I think that would be important for your academy. When I first try to understand microcirculation or microcirculation dysfunction, I truly thought it's a disease of what's known as inoca and minoca. It's disease of ischemia with no obstructive coronary artery disease, or myocardial infarction with no coronary disease. However, as we progressed in building and doing cases and building a registry here at the Washington Hospital Center, I started understanding that CMD, or coronary microvascular dysfunction, could play a role, not necessarily as a causation, as an etiology to these conditions, but certainly could play a role in understanding the prognostication fact. For example, all patients comes to the hospital center with Takotsubo, or at least a high testing probability, pretest probability for Takotsubo. You know, a woman that had a stress in her life, an LAD wall motion on echo, some EKG changes, some biomarker elevation, and we need to do an angiogram to kind of understand, is this obstructive or non-obstructive Takotsubo or not, with the same wall motion on LVgram. We can send those patients to be part of our CMD registry. And the reason for that, I don't think microcirculation is the reason for Takotsubo, but I could certainly start thinking about, is the elevation of resistance or the reduction of the coronary flow reserve in my testing can predict recurrence of Takotsubo, can predict recovery of Takotsubo. Same thing with postpartum or peripartum cardiomyopathy. Can I tell a pregnant woman, based on her index CMD testing that you will have high likelihood of having the disease in the future because your microcirculation is completely dysfunctional and fell apart? Or can I say, you know what, with good medication regimen, we might be able to get you pregnant? Same thing with myocarditis induced by chemotherapy. Is cardiotoxicity a disease of chemotherapy or immune check inhibitors affecting the myocardium, or is it mostly driven by the CMD? So I do believe CMD is a link. All these conditions that you see in your practice, you see in your institution, and you might be able to start thinking about microcirculation as the cornerstone that links everything. Is this too boring or we're good? You can give me thumbs up. Okay, good. So now let's talk about how important this disease is. Hashim passionate about this? Is that why people talk about it in Twitter and Instagram? Because it's, you know, it's a new thing in interventional cardiology, or at least a new diagnostic tool in interventional cardiology. Well, these are statistics from the NCDR, from the National Registry in the US, on all patients undergo angiography, and all patients undergo PCI. So let's think about this. On my schedule today, I have 10 cases. 4 of those 10 cases, they have abnormal stress test for chest discomfort, or they had a CT angiography, a CCTA that showed a CT FFR of an equivocal value in a setting of a clinical scenario that indicated that those patients have enough evidence non-invasively to be in the cath lab. So they are here on the table. We're going to do coronary angiograms on them. If you have done nuclear, this data was done on patients who had received myocardial perfusion imaging with SPECT, with nuclear. So this is what we see. You have 4 patients with an abnormal nuclear stress test. 1 will get a stent. That's historical from NCDR. 1 will probably receive a physiology testing and imaging testing, trying to understand or tease out a moderate stenosis. 2 of those patients will be told, you're good, no blockages. So if we take the 2 that were told you're good, and we test them for vasospasticity, or we test them for microvascular dysfunction, 30 to 50% of them will have a disease. Which means now, to you and the academy, as research fellows and clinicians, you probably start thinking, can we define the sensitivity and specificity of the non-invasive testing? Because historically, you can tell me, oh, nuclear will have a false positive of 17, 20%. Well, maybe that's not true, because the way we validated that is by doing an angiogram and saying no blockages. I did not validate the actual perfusion, why that perfusion was abnormal. Same thing with PET-CT. PET-CT could say, you know what, you have a problem, it's very sensitive, and then you do an angiogram and you don't see the problem. Does that mean that the PET-CT is wrong? Or that means your angiography is not enough to explain the PET-CT. For that reason, there is a lot of new literature we are part of to redefine sensitivity and specificity rates of every single nuclear stress, every single stress test modality, because you might test them for CMD and they have microcirculation. That could be the reason for chest pain and the stress test. So it's a very prevalent disease. It's a disease that affects predominantly women. So if you are part of institution that actually deals with women cardiovascular conditions, peripartum cardiomyopathy, breast cancer, and immune check inhibitors, cardiotoxicity, SCAD, FMD, all these things, you could probably fit your CMD testing into that population, because it's a disease, unfortunately, affects more women than it does with men. Still affects men. It's often overlooked. This is from our data. This is from our registry. Look at this graph. I don't need to go on a lot of data. But the time it takes to give the diagnosis is 2 years in the US. It requires at least 2 visits to the emergency room with chest pain. Those patients, they don't want to go to the emergency rooms. If you come to, God forbid, to my emergency room, the wait is about 4 to 6 hours at peak time. It's overwhelmed with a lot of patients. You don't want to come if you have fake chest pain or it's chest pain in your head. This is a condition that bring patients to the hospital. They come to the hospital. It takes a lot of resources before they get the diagnosis. How do we diagnose it now before we go to the cath lab? Well, the gold standard historically has been CT. You do a PET CT, PET stress, and I will give you the CFR in every single artery. I'll give you CFR globally, and we use coronary flow reserve as a surrogate for microvascular dysfunction. There are multiple sequences now in cardiac MRI that are being developed to kind of understand the myocardial perfusion and microcirculation perfusion in a better way. Invasively, we have two ways in the cath lab. The cath lab, we have two ways to understand it, and I'm going to go over it in a second. One is Doppler wire, one of it is thermodilution. But before I go there, I will bring you into understanding what CFR is, what RFR is, all these alphabets that's being thrown at you when you read the literature. You kind of don't know. Okay, there's so many of them, so many FRs, RFR, IFR, DFR. Like, which one do I do? What does that mean to me? First, let's talk about CFR. CFR is the coronary flow reserve. In layman language, the way I understand it, if I'm talking to you now, I'm giving my coronary probably 2 liters per minute. I'm just using an arbitrary number. This is not an actual number. So I should be able, with my resting status, to give you 2 liters per minute at rest. If I run out and come back, for me not to have or develop chest pain, my coronary flow should be able to augment by at least double, which means if I start with 2 liters, I should at least give my coronaries 4 liters. This way, my heart doesn't provoke chest discomfort. This number came from the fact that when we studied dogs, animals back in the day, and we ligate their LAD, when we reached a stenosis of 70%, the coronary flow start dropping. And those dogs and those patients start having chest pain, EKG changes, and compromisation in the flow. This is why when we talk to our patients, we say, you know what, 70% and above, I'll most likely put a stent, because that number correlates with a drop in the coronary flow. And once you drop the coronary flow, you will have symptoms. For that reason, any normal human being should be able to augment their flow by at least double, since CFR is defined by a ratio of 2 between rest and exercise. And when you read PET CTs, any value below 2, you will be called abnormal coronary flow reserve in this artery or globally. Now, where is the issue? The issue comes, coronary flow, as you see in this bracket, is a representation of your epicardial and your microcirculation, which means if I have inability, if I cannot augment my flow, is this because I have a 90% Prax LAD, or is this because I have microcirculation disease? How do I tease epicardial disease in the lab? I will tease it by FFR, RFR, any IFR, anything. We know how to do this. The FAME sequelae of trials told us that FFR-guided PCI is not inferior. FFR-guided PCI change your assessment. FFR-guided PCI changes, or physiology-guided PCI changes your decision-making. So we know how to do this, which means if I send you a patient with a PET CT CFR of 1.5, oh, abnormal, and you had CT coronary angiography, and you saw that there is no epicardial disease, and you further so did the CT FFR, and you have no obstructive epicardial disease and low CFR, does that mean you have a problem with the microcirculation? This is the questions that we are trying to answer as interventionalists. So if I cannot augment, and I have non-invasive testing telling me that my epicardial arteries are normal, then by virtue of exclusion, I have microvascular disease. That is true and false. Why is it true? It's true because CFR represents these two. That's why CT has always been the surrogate for microvascular disease, especially if you have someone with chest pain. However, we start understanding when we did invasive testing that there are certain conditions that could lead to low CFR in absence of microcirculatory disease. Those patients are walking around everywhere. They have low CFR from something else, has nothing to do with the coronary circulation. That's why we needed an index, which is the index of microcirculatory resistance, kind of define, is the CFR low because of microcirculation disease or not? How do I know CFR in the lab? This wire has been taken out of the market. but we believe that Philips is going to bring it back again in the near future to the market. And it's literally, that's how we do echo. You put a wire down, and you do an ultrasound on the heart, and you measure the velocity using CW, and then you track the curve, and you calculate VTI. And then once you get VTI, you could know the stroke volume, you could know the aortic valve area. This is how we did with echo, using Doppler to understand flow. So here, you put the wire down the LED, circ, anywhere. You measure the beat to beat, 3 beats. You say, you know what, the coronary flow is 4 liters per minute. Okay, exercise the patients, do hyperemia, and then measure the CFR at exercise, and you'll be able to tell me what the CFR is. Very simple. However, the signal accuracy, there are some limitations. That's why it's taken out of the market, and hopefully we'll bring it come back. The other way is to use what's known as pressure wire X, which is a readily available FFR wire. This is a pressure sensor wire. We used it for years. But apparently, we didn't know that there was a sensor right next to the pressure sensor. It's a temperature. It measures the change in temperature between point A and point B. It's very similar to right heart catheterization, thermodilution assessment, or translation of flow, which means if I know how much I'm injecting, if I know the volume, and I know the time it takes for the change in temperature, volume over time will be surrogate or will be your flow in that certain chamber. So that's why we inject in the right atrium. We wait for the saline, the 10 cc of saline, to reach the tip of the PA catheter, because I know that I have one port in the right atrium, one port in the PA. I could tell you your cardiac output. This is how I did right heart cath. This is how it's done everywhere in the world. Thermodilution. In your LED, it's a bit different. No one wants to inject 10 cc's of saline in an LED or a circ. You're going to have saline is not a oxygen carrying solution. You will have VFib, you'll have ischemia if you keep injecting saline into a coronary. What are you trying to establish here? For that reason, I inject only 3 cc's. And if I will measure the time it takes for the 3 cc to leave the guide catheter and reaching the sensor on the wire, that time will be surrogate for my coronary flow. This is how we do it. This is a guide catheter. This is my hand. One of my fellows did this on an iPhone. There's no rocket science. Reservoir of saline, room temperature saline. I fill my medallion syringe. Then I will inject it down the coronary, a guide. I'm using a 7-inch French guide here because that's the only guide I have disposable and open. I didn't want to spend money to open a 6 French, but you could use it with 6 French. So that's the whole idea, injecting and measuring the change in temperature. This is what the machine will tell you. You've probably seen this in your institutions. This is technically, I'm injecting saline at rest. I'm using the time it takes to change the temperature as a surrogate of flow. Now, obviously, if there is any outlier, you delete them. You have to have a homogeneous reading, just like you do cardiac outputs with right heart cath. Same thing then, I induced patients hyperemia. You can do it with continuous normal saline infusion down the coronary. You could do it with intracoronary adenosine, or you could do it with IV adenosine. I use IV adenosine because that's what my lab is used to. And we don't have what Europe has, which is the FSCAI catheter, is a microcatheter with multiple pores. We don't have it in the US, or we actually have it, but it's a bit expensive. And for reimbursement reason, we don't use it. With that, you could do a more stable hyperemic phase with infusing normal saline down the coronary. Here, these cases that I will show you, they are all done with intravenous adenosine at a dose of 140 mics per kg per minute, which is the regular dose to induce hyperemia for FFR. I measure the time at rest, measure the time at hyperemia, I'll take the ratio, and the ratio will be my CFR. IMR, the index of microvascular resistance, is calculated by the machine, or you can calculate it yourself as well. It's Ohm's law. It's literally the resistance equals voltage and current. Voltage times current. Voltage is the pressure distally at hyperemia, and the current or the flow is the time at hyperemia, which is the surrogate for the flow. And then you will get your microvascular resistance. It is abnormal in this testing to have a CFR of less than 2.5. It's abnormal if you have an IMR of above 25. So normal values for index of microvascular resistance using thermal dilution is anything less than 25. And CFR should be above 2.5. That would be normal. Any other combination, that will be abnormal. Any questions so far? Perfect. Now, I don't want to
all clear.
indulge.
And Hayder, I have to say that the passion that you are putting in this is really amazing. So also, if you're not interested in this field, you would love it. So thanks a lot.
I appreciate it. Thank you. So I don't want to go all the way deep into the acetylcholine testing, reactivity testing, but if we are approaching ANOCA, if we are approaching INOCA, MINOCA, the way we wanted this presentation to be, you have to have some understanding in provocative testing, because the diagnosis is not complete unless you do a complete coronary function testing, which will include understanding myocardial bridge as a cause for angina with no obstructive coronary disease. But I cannot cover all bases. Here, this is my protocol. This is the protocol that the Microvascular Network in the US had put together. We sat down, we said, let's unify this. We use acetylcholine, and incremental dosages. Obviously, if you're on the left coronary, the dosage is a bit higher because you have to cover LAD circ, and the right coronary artery is a single vessel with less branches. A lower dose of acetylcholine is enough to test for vasoreactivity. The way we make the diagnosis is simple. If the patient gets chest pain, 12-lead EKG changes without angiographic evidence of spasm, when you do a puff, then you have microvascular spasm. If you have chest pain, EKG changes, and you shrink the coronary artery by at least 90%, which means almost near obliteration of the coronary circulation, then you have epicardial vasospasm. The antidote to acetylcholine in the coronary is nitroglycerin, which we're very used to give. We give nitroglycerin before every imaging. We give nitroglycerin before every physiology. We give nitroglycerin when we put stents. We love nitroglycerin. We use it. When patients get hypotensive, we freak out, we give fluids. We know how to use it. But guess what? That nitroglycerin is the magic that will immediately plumbing back your LAD if the LAD collapse. First few cases of vasoreactivity, you get that small chest pain yourself, epigastric pain, because you see the LAD collapsing, the ST is dropping, or ST elevations. You might get some sinus arrest, like not AV nodal arrest, sinus arrest. Matter of fact, you get flatline, but all these things are reversible with nitroglycerin. And this is how it looks. And just quickly, this is a baseline. This is how I do it. And then this is at the highest dose, complete obliteration of, like you think patient is this an air embolus? What's happening? Nerve-wracking. This is one of my first cases. I threw up a couple of times after that. And then once I give nitro, boom, it's the same exact patient, no chest pain. So it's a very dangerous looking angiogram, but it is truly a fascinating. Now, if you don't believe me, you want to start this, you say, you know what, this guy's nuts. This is what Takayashi and Yuri Kobayashi, they were fellows at Stanford, and that's what they did. They looked back at all acetylcholine provocative testing trials or studies, and they put them all together in a meta-analysis, 16 cases, lots of patients. There's truly no death reported with this. Yes, it is nerve-wracking, but you have to have your nitroglycerin next to you, and then with most of the problems do happen with 100 micrograms. I rarely see myself going to 200. 100 microgram, if you did not provoke spasm, go home. Who cares because I could give you a gallon of acetylcholine, I will provoke spasm somewhere. But 100 is what defined as a stoppage point to leave the patient. How much does this take? Again, Yuhi and Bill Fearon in Stanford many years ago, using thermal dilution, checking CFR, IMR in their hands. It takes about 5 minutes. It does take less than 5 minutes. There is no rocket science. You engage, you put the wire, and you're done. This is our experience. This is from the cases we've done in our registry. This is probably now a couple of years data. We have more patients now enrolled. There is a mild difference in contrast. The reason is because I have to do 3 angiographies. Remember, I have to do a baseline. I have to do another angiogram with 20 mics, another angiogram with 100, and another angiogram after nitro. So I do use probably another 10 cc extra of contrast in these cases. It does not, it does take more fluoro time, but there is no change in, there's no change in clinical radiation. The reason for that, why do you have more fluoro time? You know, you engage the guide, you put the wire down, you do some angiograms. But if you translate to radiation safety, there's not much radiation to you as an operator or to the patient. That does not clinically. It's just a couple extra minutes of fluoroscopy. And in our institution, we do every single thing on 7.5. So there's not much radiation in fluoroscopy. Is this in the guidelines? Yes, certainly. I'm trying to catch up on time. Is this in the guidelines? Yes, this is the European guidelines from last year, also updated, that if you have symptoms, persistent symptoms, you've done every single thing in your arena, you need to start thinking about understanding the microcirculation with CFR and with IMR. Same thing, it's reasonable to consider invasive coronary function testing for patients to aid or improve the diagnosis of ANOCA, MINOCA, or INOCA, because we truly lack understanding of this disease in the European guidelines. Many of my referrings come from different institutions. Hey, man, we stented this guy, we stented this woman, still having chest pain. They bring the patient back, they do OCT, IFR, they try to understand if the stent is wrong, if there's anything they missed, and there's nothing there. How come? We put a 4-hour stent in a Prox LAD and we're still having chest pain? It's in your head. Well, the conditions of epicardial and microcirculation could coexist, and that takes us to the first slide. If you have structural changes in one, you should have structural changes in the second. If you have functional changes in one, you'll have functional changes in the other. So you could have 20 to 40% of patients that have coexisting epicardial disease that you solved, but they still have chest pain because they have microvascular dysfunction. Is this important? Again, Hashim, we understand this is common, but who cares? I want to see something translate into events, translates into mortality. Is that true? Let's look at the data historically quickly. If you have low FFR, you have events. That's why we do FFR guided PCI. If you have low CFR, if you cannot augment for any reason, you are in trouble. Why? Because you need your coronary flow to stay alive. You need to exercise without having chest pain. You remain active. So low CFR is no good. Low FFR is no good. But if we take the patient with low CFR, cannot augment because of an elevated IMR, they actually get D in their test. They're horrible. They're going to have a lot of events. They're going to have MACE. They're going to have issues. Have higher mortality and shorter lifespan. If they truly have a lack of augmentation.
Hayder,
yes, sir.
Let me ask you a question. So,
yes.
But this higher mortality and higher event rate on which is it the long term? That's days.
Long term, yes.
On the long term. So this is associated with a reduction in the possibility of doing exercise, as you said, or do you think there are more arrhythmias? Which are the causes for these events in this group?
Okay, so I will show you I asked myself that question. Is it related to lack of functional capacity? And as we know, longevity of human being is how active you are. Or is it related to arrhythmia? I'll show you the publication that we did from our registry. Now, most of the publications I'm going to show you, they are from single. We are building the registry. The registry now is global. A lot of institutions are putting into it, so we'll have better data. But we capture AFib, VT. If you have a link, if you have like a loop recorder for some reason, if you have a defibrillator, a pacemaker for some reason, we take those data all into the registry, trying to understand. Some of them is related to arrhythmia. Yes, sir. They do. I will show you. But it's an area of interest in research. Is there a way we can track those patients with every 6 months come in, we put a monitor on you and you go try to capture more. I need more prospective than retrospective. My registry has only 150 patients prospectively followed. We call them, we ask them if they have any admissions, if they fill Seattle questionnaire for angina, since we give the diagnosis. But I need more people like you to start thinking, what's the reason? Is the reason CMD and hormonal? Is the CMD and craziness? CMD and shoe size? I don't know. I truly don't. Why they die? To be determined. So this is also know post PCI. If you do a PCI for any reason, you check IMR, and if you did a lot of rotational atherectomy, you did a lot of laser atherectomy, you have a large thrombus burden. The more you occlude, the more you increase the microcirculation resistance, the worse outcome you will have. Established, done. This is post PCI. Unstable coronary disease. In MI, it's even worse. Because if you bring someone with a large thrombus burden, and we mock around, we do thrombectomy certain cases, we just inflate the balloon to stop the clot, door to balloon time. Some of that showers go down the microcirculation. If I had included all patients with IMR above 25, which is what we define, almost everyone post-MI will have microvascular disease. For that reason, the cutoff was lifted to 40. Because we anticipate, as a pathophysiology, you'll have microvascular edema, you have radical oxygen, free radical oxygen compounds, and you will have iatrogenic debris going down. IMR will be elevated post-MI no matter what you do, with the best technology we have. But IMR of 40 and above does signify that you will have major cardiac complications, including the lack of full recovery of the LV or infarct size based on cardiac MRI. This is what those guys had told us in 2017. Small sample size, but they measured IMR in STEMIs and NSTEMIs after PCI in the same settings, in the culprit artery. And that's what they were able to tell us. So this is the workflow that we published in the Microvascular Network. And it's a state-of-the-art paper in JACC in 2023 September issue. It's 2 papers on how to build and how to make a diagnosis. But this is technically the workflow. This is what I follow in my practice. You send me the patients with ANOCA. This is the workflow. I will do an epicardial coronary artery. Now you could send me the patients with any test. It doesn't matter. An angiogram. You have a low risk of obstructive CAD. You have stress. You've done stress. It doesn't matter. You're here. I will do an angiogram. Less than 50%. You have no obstructive coronary disease. Far above 0.8. My patient resting of 0.89. Done. Coronary function testing. You do CMD testing, acetylcholine testing, and you do coronary physiology and IVUS for the bridge, and then you put your patients in these buckets. You will get your diagnosis. You will have to fit the patient somewhere here. There are different endotypes we'll talk about in a second, but this is technically it. This is the workflow. You take a picture of this, put it on your refrigerator. That's how you should approach any patients with chest pain when you don't find any non-obstructive coronary artery disease. This is our paper. Benny is one of our interventional fellows, published this last year. It's part of it's going to be a book. This was an invited review for CRM. And this is exactly each phenotype, because when you do the testing, you might have colliding measurements. You might have a case with low CFR, you cannot augment, but normal IMR. What is the disease? So the disease would be low CFR, IMR is functional CMD. Why do you have functional CMD? What does that mean? That means you have increased vasoconstriction, you have decreased vasodilation, you have sympathetic stimulation, you have parasympathetic inhibition, you have inflammation from myocarditis, from cardiomyopathy, from amyloidosis, something that's leading you to not augment, but your IMR is normal. So if you study this and you have understanding of this, you will know where the treatment target would be, and then how should you define the pathophysiology. Now, I got to give you the caveat to this. This is what's available in the literature. This is a review article. You might come one day from your academy and say, you know what, stop, come back. The low CFR, normal IMR, just the lack of augmentation, you said it's called functional because of this. I proved you wrong, because sometimes if you do this, you get that. These are areas, whatever I put here, they are all areas of research trying to understand how can I explain a very elevated IMR, but I still able to augment. We call that compensated, which means despite the fact my IMR is 40, my CFR is 3.2, how come I still augment flow? Because the coronary tree, it's so forgiving. The goal of the circulation is to maintain CFR at all times, at all costs, even when the resistance in the microcirculation is higher. Maybe the treatment for those cases is to give nitric oxide. How do you give it? I don't care. It might be L-arginine. You might give the amino acid that leads to the formation of nitric oxide. You need to tell me. It's for people, clinicians interested in research to give these answers on how to solve this problem. Formica trial, I'm going to try to skip quickly, but just Formica trial is the pivotal trial that led to this whole diagnostic spiel is if you give a diagnosis, you do make a difference, even if you don't have the good treatment yet. Even if I cannot tell you with 100% certainty, this is what you need to treat the patient with, just giving a diagnosis for someone who's been frustrated, walking around, going to places, switching from a cardiologist to another, looking from an institution to another, giving the diagnosis makes a difference. And that's what the trial tested. All patients had the, if you look here, everyone got the testing. Everyone got testing. One group was told, you don't need bypass, you don't need stent, get out. And those patients will look up to you and say, so what do I have? Well, you know what? You don't need bypass, you don't need surgery. I could answer that. I don't know what you have. Go and then deal with yourself. And the second cohort, we told them you have CMD, you have vasospasm. You need to take this, you need to do that. And let's test you back when you come back. And that's what we found. We found that the patients who know the diagnosis, they perceive their illness better. They're not sick all the time. They start taking family trips. They perceive angina differently. What they described early as class 3, I can't even, if I have a haircut, I have angina. They now have a lot of haircuts without angina. So they start perceiving angina differently. The quality of life as a result improved. And the adherence to medications improved. Because imagine you come to me and I tell you, you know what? You need to take this chemotherapy because I think you might have cancer. You're going to say, oh, this doc is crazy. You can't get the chemotherapy. Well, same thing here. If I don't give you a diagnosis, why would you take nitro? Why would you take amlodipine? I need to give you a diagnosis to treat you with a medication. This is the treatment that was described or recommended by the trial. If you have microvascular angina, you don't see nitro as part of the treatment algorithm because nitro is endothelin dependent, as a nitric oxide, as a epicardial vasodilation. That's why when we put a stent and we see a small wrinkle at the end of the stent, we reach to nitro. Hey, give me nitro. Let's see if this is a dissection or this is stent-induced spasm. We don't do adenosine to release epicardial spasm. We use nitro because it's endothelin-dependent mechanism of action. It goes into the cellular level and it will flood the cellular level with nitric oxide. That's nitroglycerin. So for that reason, if you have microvascular circulation, you could give 3.5 gallons of nitroglycerin. Nothing's going to happen. It doesn't work on endothelin. It does not work on the ADP receptors. If you have CMD, pure IMR elevation and reduction in CFR, this is the treatment. The treatment has nothing to do with nitro. If you have vasospasm, on the other hand, there's no beta blocker. When was the last time you had a patient with chest pain and you did not give them beta blocker? That's like, it's almost everywhere. It's like the same idea. You get chest pain, you pop aspirin. Even if the chest pain is from someone punch you in the chest. Aspirin is readily available. Beta blocker is so cultural in our field that we give beta blockers to almost everyone because guess what? The heart works less heartbeats, less consumption of energy, less contractility, will feel better. But if you have vasospasm, beta blocker is not part of the treatment. Matter of fact, it could exacerbate the problem. You need something else. So for that reason, knowing the diagnosis of ANOCA and the reason behind it impacts your treatment. This is what we recommended in the second part of the JACC paper that I showed you the first part. This is what we believe is in the treatment. I'm going to run quickly here. This is our registry, Ron, Brian, myself. We built. It's free of charge. Everyone could enroll. This is our experience. We've started doing a lot of cases since 2021. We built a lot of patients. Now, I'm not saying this is the gold standard of how doing things. I still do them radially. Some of my institutions that are part of the trial are femorally, which provides a lot of help because now I could compare radial versus femoral testing. Because does radial cause spasm, and that could contaminate my spasm testing? Can I give cocktail or don't give cocktail? Is 5 French different than 6 French? This is the technicality for Dr. Cortez. Now, the technicality of doing the test is different. Do you use CIRC or LAD? Do you use RCA or LAD? That I will answer, or we will answer from the registry once we have more patients and more spectrum of how to do things differently. Some of the European sites are sending cases with continuous saline infusion down the coronary, which rarely Olga and Emery does it, Tim Henry does it, Amir Lerman does it, and Mayo, but not many centers does what European do. So we will understand more on this. Multiple publications. We sat down, we reviewed every single one. If they have a CT scan for any reason, we measure the epicardial fat. Guess what? If you have high epicardial fat, you have high risk of CMD if you have chest pain, proven invasively. This is from the trial. Arrhythmias, wow, arrhythmias, that's what we talked about. Yes, they can have arrhythmia, and 1 year. There is a indication that those patients might have arrhythmias, and that could lead to issues. And you see that there's higher likelihood of having all sorts of arrhythmia, especially ventricular, which might be the reason for why they die eventually. I don't know. I truly don't know. I don't have that follow-up. But historically, when we looked back, we said, oh, you know what? Some of those patients with ANOCA, when they tested positive, let's look back, we see they have a lot of PVCs. They have a monitor that showed a lot of non-sustained VT. They have a pacemaker that detected ventricular arrhythmias. So it does make a change. CMD and cancer. Is that the reason? Maybe the patients with cancer, they have cardiotoxicity because of CMD. That's another publication that we led from the registry. Obviously, the disease is recognized now as ICD, and ICD-10 code is an international coding. So if you're in your institution and you diagnose someone, you could actually write down, just like you code them for hypertension, you code them for PCI. You say, you know what, this patient has angina pectoris from coronary microvascular dysfunction. The CDC here in the US announced this in October 2023. I was part of testifying in front of them to tell them that this is a true disease. There's enough evidence that you need to name this as a true diagnosis. It's not in your head. You probably know this better than I do. We are part of the trial. Tomorrow, I'm doing 2 cases in the US trial for the FDA approval. This is a coronary sinus reducer, is already established in Europe, other parts of the world, since 2015. We are still a few years behind you guys. But this is it. This is tomorrow. I'm doing one for someone in a registry with a low CFR. I brought a patient in, tested them, and they have chest pain. And then we will do it. I don't want to go over it.
I can confirm, Hayder, that this device is working also in OCA patients. I used it several times. Of course, at the beginning, you started using it for refractory angina in non-revascularizable patients, but then we started using it in microvascular angina, which is actually an exclusion criterion for the US trial we are participating to. But I think that, in an off-label fashion, you can use it.
Yes, you're 100% right. It's this. We sit on the steering committee, and then this is this trial. This patient, if you see, has a lot of stents, bypass already. You see the markers. This bypass graft is full of stents. This coronary artery is full. This was a no option. That was one of the Coursera 2 cases. I'll conclude by taking you back to our case. This is the case I did. We have an abnormal stress test, chest pain, couldn't find anything. The RFR was normal. The FFR was normal. Now what? Remember, I tested her for acetylcholine. I started giving her 2 mics to understand endothelial dysfunction. No EKG changes, no symptoms. I went up to 20. No EKG changes, no symptoms. I went to 100. no EKG changes, no symptoms, you might be able to see that the LED is a bit narrower than what I started with. But guess what? I'm at 100, no symptoms, no EKG. This is not her chest pain. I could give her probably 200 micrograms. I could give her 500 micrograms, but then I'm not provoking what she is on the table for. I want to understand, is her chest pain spasm or not? I don't want anyone else to start thinking, you keep doing it until you find it. No, that's not the right way to approach this case. The case, you have chest pain, you can't explain. Your goal is not to provoke chest pain that the patient doesn't have. Your goal is to provoke chest pain that the patient has. So I gave her 200 mics of nitro. I did the testing. You see that at rest, she has a 1 second time that shrunk to, so she was able to augment, but guess what? Her CFR was less than 2.5. Her IMR was 34. She has pure structural microvascular dysfunction. This is as textbook, as typical I could get, that you have an elevated IMR, lack of augmentation. That's why she has exertional chest pain. The nitro that she had headache with is no more part of the treatment. I say, you know what? Leave the nitro. Amlodipine might be useful because it's a calcium channel blocker, but maybe it's time for non-selective beta blockers. It's time for ranolazine. It's time for me to send you to cardiac rehab as much as you can to start recruiting more microcirculation to improve your CFR, because you're on the borderline. If you have a tiny bit more CFR augmentation powers, I might be able to get you out of chest pain. And she got the diagnosis, she ran with it. This is how we worked her up. She had the stress test. I did the cardiac angiogram. I did coronary function testing. How did I do it? Acetylcholine first. You could ask me why acetylcholine first, because the antidote is what? Nitroglycerin. And before I put any wire in the coronary, I give nitroglycerin. So for that reason, my sequence is do the spasm testing, give the nitro, you're going to give no matter what, because you're going to put a wire down, and then put the thermodilution wire down, the wire down. She has low CFR, high IMR, she has coronary microvascular. I gave her disease-specific treatment. This summarizes how to approach patients with ANOCA, INOCA, MINOCA. I did not talk about MINOCA because those patients in our institution, they get OCT of what we think is the culprit vessel, or OCT of all vessels as part of a trial, followed by CMD testing, followed by cardiac MRI, because the gold standard to understand why you have biomarker release is to do cardiac MRI. At least in our practice now, within a week, cardiac MRI could differentiate a true infarct, subendocardial ischemia. It could give you edema from myocarditis, from Takotsubo. So we're collecting data for a trial where if you come in with MINOCA, truly objective finding of troponin elevation, and you have no blockages, I either do OCT on what I believe is the culprit, or I will give you OCT in all arteries followed by cardiac MRI. So in conclusion, the etiology of chest pain is a spectrum. You truly need a full assessment of the coronary circulation. The days of you don't need, we're very good at telling patients what they don't need. You don't need bypass, you don't need a stent. But I didn't tell the patients what they have. I told them what they don't need, which is they're happy with, because nobody wants to have a sternotomy. But that's not the goal of why you're having chest pain. I need to give you the diagnosis. The days of it's in your head, oh, this patient is crazy. Oh my God, she called back again to the clinic. Oh, tell her I did every single thing. No, if you have not done coronary function testing, you have not done everything. And the days of ruling out is over. We need to have rule in and give a diagnosis to our patients. With that, I'll stop. I'm happy to answer any question.
Thanks a lot, Tyler. Really, really passionate and competent and high quality presentation. I'm really, very happy of having you here today.
Thank you.
I really appreciate. Yeah, do you guys have questions? Bharat, what's the time there? It's like midnight? No, it should be 9 p.m.
Yeah,
Still acceptable.
it's 9. Hello. Thank you, Dr. Hashim. What a fantastic talk. Probably one of the best I've heard all year. So thank you very much.
I appreciate it.
Thank you. I just had one quick point. I think Devika Pereira's group a couple of years ago showed positive exercise stress tests, a simple treadmill test, and 100% specificity for Inoka. What is your take on that? So should we be taking these patients to the lab and going, okay, you do the angiogram, unobstructive coronary arteries, but then you proceed on to do the functional testing and get them to diagnosis, rather than doing stress echoes or nuclear scans or even CTCAs?
Yeah, so my take is there is another publication in JACC Intervention that we wrote an editorial to. This was one of the points that I wanted to emphasize. I am truly in the market now to redefine specificity of what's always was called non-specific. We always blamed EKG changes. You know what? It's very sensitive, but it means nothing because you know what? You put the patient on the table and you find no blockages. So that ST depressions, take them and put them in the closet because they are worthless. Matter of fact, that's not. I do agree with Vivek and his group. We need to redefine, and that's why we need people to start thinking about this. That this bucket nuclear stress test, what's their CMD testing look like? This patient, this group is PET CT, what their CMD look like? Because then in a large cohort we can redefine the specificity. And I do believe EKG is very sensitive because it's truly picking a very unique problem. And it's specific for microcirculation. I just sold, not sold. I have to stop saying this. I gave the data access from the registry to an AI company that will look at resting EKG, trying to correlate with CMD. This is how AI is going. They took it. There's another company that took angiogram. I gave them through a grant the entire angiograms that I've done of all the registry patients, and they are trying to understand CMD just from regular coronary angiography. So the future holds a lot of good stuff because we have a way to validate the disease.
And the one other question I had was follow-up CMD testing. Is
Yes.
that, you get the patient on medical therapy, they feel a bit better, but still, really want to know whether there's been an improvement. Is there any role for follow-up CMD testing?
I think there is. I have only 5 cases, and out of 470. Do you know why I have only 5? They came back for something else. I did an angiogram. It's hard for me to find the funding to repeat an angiogram. For that reason, prospectively, we're using surrogates from the literature, which is Seattle questionnaire. Have you been admitted? Did you have another abnormal stress test? Things that we believe can be used as indicators of worsening, recovering, or plateauing CMD. Hopefully the day will come if we have a non-invasive way of validating CMD. That will be the answer. And that's when we could start testing medicines. Because give you a pill, go do this test, come back. That's why, Bharat.
Yeah, maybe
you do it
with the heart flow CT scan. Maybe we will be able to find some new softwares to understand.
Yeah, and also I think QFR
or MRI. I don't know.
Yeah, QFR.
Yeah, but for QFR, you need to recap the patient, So we're talking
that's
about
the problem. I spoke to Medis.
Non-invasive assessment.
I'm very close with Medis. We published the cancer IMR based on angiogram using QFR, using their angio-derived IMR testing from Medis.
Yes, we are presenting a study at TCT on that.
No, I know you are. So that's the thing. So yes, but again, you need to recap the patients. We need to find that solution that you put your phone on your chest and I'll get you CMD or not. Then we have
but just to understand better, clinically you want to see a patient. So you do the test, it's positive, its IMR is more than 25. You change the treatment. You want to see the patient after how many months? 2, 3 months, 1 month?
I do 1 month, 6 months, and 1 year.
Okay. And in your experience, how is the improvement in these patients, in these purely microvascular disease patients?
Yeah, it's tremendous, Bernard. I'm saying because I'm a great physician. I say it because I truly believe in the diagnosis. Those patients, there's a lot of patients, they start crying. They're like, you know what? You found the diagnosis. If it's CMD, the toughest population is vasospasm. I have certain patients, I've referred them to our interventional radiology colleague or interventional anesthesiologist to do stellate ganglia block.
Yeah.
That's the only way I could stop the freaking vasospasm. There's no way.
That's extreme.
The extreme. But I have 2 of those patients. They went in, inject, they're off the grid. They feel great. But because I tried nitro patches, Mdor, like isosorbide, I shampoo their hair with nitro. It doesn't matter. They have spasm no matter what. So I go to the extreme, stellate ganglia block. It is what it is.
Amazing.
Good.
All right. So I think we are good. We are past the time that is allocated to this lesson, but it was so passionate and so high quality that really we enjoyed every single minute of it. Really, really.
Oh my God,
And
it means a lot to me.
Yes,
we will reinvite you soon. And this is your fault. You did such a great job that hopefully we will see you in 6 to 12 months here.
Again. I will do whatever. Absolutely.
Thank you so much.
Thanks a lot. Thank you very much.
Thank you.
Thanks for staying late for me. I appreciate it.
Thank you so much. Thank you.
Thanks.
Thank you.
Thank you.
Thank you. Bye-bye.
Thank you. Thank you so much.